Thank you very much indeed, Srini. I think I have a lot of interesting practical point discussions going on in this session. Thank you very much. So, rate lead transplant. I think one of the first question is what is early versus late? There's no clear-cut definition on that, but then generally most consider more than 30 days after the primary transplant as a late transplant. Early retransplant, I think one of the things is it may be technically easier because a lot of the dissection is done and it hasn't not much adhesions that happened. But then interestingly, the mortality is actually higher when you have a early retransplant. It's predominantly because of the causes that differ between the two. Early retransplant, I think majority are for hepatic artery thrombosis, but then now in the living donor scenario, because of lack of cadaveric donors, a lot of thrombolysis and stenting has been done. So that number has also come down a little bit. Port vein thrombus, I think often difficult to salvage. Same hepatic venous outflow obstruction. And then primary non-function or severe dysfunction is rare in live donors, but still it does occasionally, it does happen. Compared to that late retransplant, most of them are, I think, are probably because of the initial biliary problems, that is there in live donor liver transplantation, and then multiple cholangitis and secondary biliary cirrhosis. That's one of the common causes. Secondly, I think rejection. So once you go on to steroid-resistant rejection, salvageability becomes very limited, and then you probably end up with a transplantation. And chronic rejection, again, because of poor compliance, added on by recidivism, that can be a problem, and recurrence of primary disease. So I think preparation, unlike an early retransplantation, we have a little bit more time for a detailed evaluation. So cross-sectional imaging, of course, it's a must, because usually we have multi-phase CT. Occasionally, if they have renal problem, we may require an MRI, because we need to see where the hepatic artery is patent up to, where is the portal vein, how are the hepatic veins and IVC, etc. So any reversible causes like recurrent HBV, particularly if you go back and look at the core antibody of the donor, because sometimes that may be missed, and that could have caused the hepatitis B in the recipient, and often that's not looked into. Likewise, CMV and HCV, etc. should be addressed. And family counseling is probably the most crucial, because it could possibly be a third family member, because first two are going to be related, and then there's maybe another family member that is coming into it. So they need to be aware that there's going to be a much higher risk than the primary surgery, that they have to be cognizant of the much more higher blood transfusion load that may be required, prolonged ICU stay, perhaps need for dialysis, and of course, the costs are going to be so much more. So, and I think oftentimes the reason why retransplant doesn't occur is probably because of these costs that come in the picture in India. So coming to the technical aspects, I think there are 4 situations. So first is an LDLT, which is followed by a second LDLT, which is perhaps the commonest in areas where living donor liver transplant is predominant, like in India or Japan, Korea, etc. But then if there's DDLT available, it will be a second DDLT. Or it could be a first DDLT and then followed by a second DDLT, or rarely a second LDLT. And this situation, that is first DDLT, which is followed by a second LDLT, is the most difficult combination. So this is because when you have a DDLT, your vessels that we take is never as high as what we do in the living donor liver transplantation. So because we are a little bit more comfortable taking it lower down. And therefore, most likely, they all require conduits, particularly for the artery and the portal vein, and even the IVC. How was the original DDLT done? Was it a caval resection or what is a piggyback? That whole thing makes it a lot more difficult. And if you look at the Japanese and the Koreans, they will say that never ever go for an LDLT after DDLT. It's always should be a DDLT after that. But then sometimes you don't have that luxury. We may have to go with an LDLT itself. So the graft liver, the donor, I think ideally go for a normal anatomy, because we don't want to end up with a type 3 portal vein and another additional reconstruction, because there will be another layer of complexity. Same with hepatic artery. We don't want 2 hepatic arteries. Ideally another single duct, because one more biliary complications, which we know is much more common, we have multiple ducts. And always keep conduits ready, arterial and venous. Somehow, look at, because now there are cadaveric donors happening somewhere in the country, we are always able to get it. So make sure that we we have get that conduits ready, usually commonly iliac vein or iliac artery, or sometimes even superior mesenteric artery is a very good conduit to be used for arteries. Do expect difficulty. Read the operation notes, where was the previous things done, was the gastroduodenal liver divided, all those things. And the explant hepatectomy will probably be the most difficult because it's going to be a lot of vascularizations. The anatomy will be distorted because the previous LDLT, it's going to be a lot of hypertrophy, a lot of new collaterals will come in the area, and because of prolonged immunosuppression, the tissues are likely to be very weak and likely to be torn. So bowel injury is again, much more common, and you have to avoid bowel injury as much as possible because even the smallest of injury, the risk of infections post-transplant is very high. If you look at UK, and in Cambridge, you go for a retransplant, a venous bypass will be standard. They don't even bother with anything else. They'll go for it from the beginning. But then in India, we are never used to venous bypass. But perhaps this is one area where if you're anticipating a difficult thing, you can get help from the cardiac team and plan for a venous bypass if required. When you do the mobilization, I think almost always we go for the previous incision, and the colon is most often adherent to the parietal wall. And in a live donor transplantation, the stomach will be adherent to the cut surface if it's the right lobe. So mobilizing, I think you somehow get to the surface of the liver, and then you start from the top to the bottom of the liver, and then slowly mobilize that. So place the it'll be never possible to put the retractors early on. So slowly as you mobilize, place your retractors, slowly retract again, mobilize further. So take your time with that. And again, as we said, avoid bowel injury. So at the hilum, dense adhesions to the omentum and bowel is very, very common. So it's often easier to come from the right to left because you can access the foramen of Winslow and then slowly get to it. Stay away from the infracolic adhesions as much as possible, and go for the hilar dissection again as high as possible, very close to the liver, because you need to get as much vessels as possible for your implant later on. Even the bile duct, I think it's not a must that we have to go for a Rowan hepatogenostomy. We can do duct to duct, and if possible, I would prefer to go for that. So duct as well, try to preserve it as a vascularized duct as high as possible. If the previous one was a left lobe, it will be stuck to the spleen. So there, dissecting away from the spleen can lead to damage to the spleen, pancreas, etc. So try to leave a sliver of liver tissue on the spleen rather than go between the liver and the spleen completely. So this will avoid splenic injury. You can use vessel sealers or whatever to dissect, leave that piece of liver tissue there so that there's no damage to the spleen or pancreas. Now, hepatic veins and IVC, again, usually that may not be as difficult unless there were previous inferior hepatic vein anastomosis. In that case, again, that dissection will be difficult. Or if the first was a DDLT where there's a complete caval resection was done. So that also will be difficult. So at that particular point, it may be useful to go for a portocaval shunt because that will actually reduce the size of the liver and it give a lot more mobility to lift the liver up. But then, of course, you may lose a length of portal vein for the later anastomosis. So divide the RHV and MHV onto the liver surface so that proximal to the suture away from the cava, and then take the sutures off for the anastomosis. Otherwise, you may end up being short on the IVC. Again, at this point, it may be useful to dissect the diaphragm quite high because in case you need to clamp on the suprahepatic cava. So that dissection also may be required. After explant, make sure that we get hemostasis on the raw surface. We have a lot of raw surface because there may be coagulopathy later on. So it's very crucial to get hemostasis after the explantation. And then we prepare the hepatic artery. Sometimes you have to divide the gastroduodenal artery to get the adequate length. Again, portal vein preparation. If the portal vein is thrombosed, you may have to go to the superior mesenteric vein. Rarely, if it's a mesenteric vein is gone, and there's a lot of shunts to the renal vein, portal anastomas may be an option. So all this has to be considered. And again, conduits has to be prepared well. Rarely, if there's no conduit available, I think you could go for the dacron or PTV as well in dire situations. Bile duct, although most centers advise HJ, I think duct-to-duct anastomosis, if possible, would be better. Postoperatively, anticipate again a prolonged ICU period, ventilation. If it's an early transplantation, this is definitely required because they may be already in encephalopathy, they may be septic, etc. In such cases, maybe early tracheostomy may give better respiratory control and lower respiratory infections. Renal replacement therapy, if required, mostly go for CRRT SLED is another option. TPN may be required because by the time they get back, normal diet also may be prolonged. Immunosuppression, because the risk of sepsis, we can keep it on the lower side, probably low-dose calcium inhibitor, low-dose steroids, perhaps basiliximab, especially if there's renal impairment. We normally give routine CMV and PCV prophylaxis in such cases. There's a high propensity for fungal infection, so you anticipate preemptive fungal treatment, things like beta-glucan and galactomannan from the bowel, etc., can be considered early for early diagnosis, because once the actual invasive fungal infection occurs, then you're losing. So I think this series from Subhash Gupta's team, where they did 29 patients out of whatever, it made up about 0.81% of their total transplants, which is actually much lesser than what will be reported in the West. Predominantly for two reasons. One is I think we just don't have the cadaver options for retransplantation. And secondly, the financial issues and the social problems. So I think because of that, the number of retransplants that we do amongst the one that is actually required is much, much less than what is there. In this particular series, out of the 29, they had a 30-day mortality of 27%, which is not bad. And they found the late retransplant had a significantly lower mortality, 16.6 versus 35% for early transplant. This is because early transplant, although it's technically easier, the patients are inherently bad because they would be septic and they would have a prolonged first stay itself. And that's the reason why the mortality is higher. And from multiple papers, the predictors of mortality, recipient age, above 50 years, even donor age also is predictive. Higher MEL score, recurrent sepsis, particularly just close to the time of retransplantation. So always, if you're planning a late retransplant, make sure that the patient is not septic at all. Secondary biliary cirrhosis, again, is another area where multiple recurrent cholangitis would have occurred. And the liver that we take out is full of infection. So that is a problem. And of course, technical difficulty where there's been massive blood loss. That is again another predictor of mortality. So I think at the end of the day, retransplant is definitely a viable option. I think we don't have to shy away from it. But then we must know that it is a much more difficult proposition than a primary surgery. So selection is definitely crucial, both the recipient and the donor. If possible, go for DDLT. And family counseling, of course, as in primary, but is very, very crucial. Thank you.
Any questions from the house?
Sir, nice talk. Late retransplantation, not early retransplant, late retransplant. The European study says that one is technical difficulty, that you have clearly mentioned. But they also mentioned that the immunological changes are more because pre-existing antibody formation of previous transplant. They recommended, one of the European Journal of Gastroenterology, they says that they always use induction basiliximab or ATG. I don't know, we haven't done. So what's your Indian scenario? Because we know in Indian patients, whenever we use ATG and basiliximab, infection rate is very high. But in late retransplant, donor-specific antibody screening will you do in such patients? Like kidney transplant, where do you do LCM cross-matching, particularly in a late retransplant?
So with the literature that I looked at, none of this is mentioned. Of course, in kidney transplant, what you said is absolutely true. They will go for an ATG induction. But in the liver situation, particularly in Indian patients, I think I will be extremely wary to go with an ATG. Basiliximab is okay, but then as an immunosuppressant itself, I don't know how useful it is. So I will not go into ATG. I think I'm really scared of it because the risk of infection is very, very high. As it is, these patients are going to be sick, malnourished patients, and recurrent cholangitis, etc. So I will not. Basiliximab, definitely, I think that's probably good. But now the cost is so much more. It's 1.8 lakhs for 2 doses of basiliximab.
Yeah.
So, but I think that may be a safe option, I think.
Thank you.
Sir, my question is actually, would you prefer a patient with low MELD and high Rosen score on background of liver
High
abscess?
what score?
high Rosen score
Okay. On a background
for
of?
a DDLT. With
Uh,
the background etiology of multiple liver abscess because of HAT.
Yeah, DDLT is definitely better. There's no doubt about that in any which way you go. But you mean it's a marginal liver, you mean?
Yes.
Yeah. Um, good question. I think it's still prefer to go for a DDLT, I think.
So I'm actually glad we are talking about retransplant, and that's a reality. If you look at the UNOS data, so 9% of the patients would be relisted for transplant. And the kind of numbers which we are doing in this country, we'll see more and more retransplants happening, and that is something, a reality which should go to every physician who's actually treating liver patients, that it is not just liver transplant, primary liver transplant. 10% of the patients might require a retransplant as well, and these are definite challenges. And in terms of Dr. Madhu, that article basically mentions about the graft failure because of AMR or steroid resistant rejections. For other viral related or other reasons of graft failure, it is not mandatory to do that. That was a suggestion on that paper. And secondly, in terms of early and late, there are various papers talking about different timelines. Like the Japanese multi-center survey we looked at last year, they divided the transplant period within first year and after 1 year. And they found out there is a significant difference in survival. And more so when you deep dive into that, most of the loss of lives are happening because delay in doing transplant. Particularly an example which was taken up, early allograft dysfunction. The trial of doing medical management goes so long that by the time you do transplant, as per that article, the mortality was 100% in transplants done for EAD. So we have to look at, so retransplant is a reality. Earlier it should be done. I mean, when we know it is graft failure, like we are talking about the MELD does not work that well in retransplant. But then, if we know it's a graft failure, earlier if it is done, you can get actually the results similar to a primary transplant. That is also published. There's an article which last year it came out in December. 25 cases, close to 95% long-term survival after retransplant, which is as good as a primary transplant. So important is timely doing it, accepting it. Most of the problem what we face is, as sir has rightly pointed out, third donor, family to understand, and that delays the overall process. The patient starts to go into sepsis and the multiple problems are happening. That is what is causing main loss of life rather than the other reasons.
I couldn't agree more with what you said, all the points you said. Number one is, I think, because we're young in terms of transplantation, for the last 10 years, so we're going to see more and more transplantation. And I think really we should consider early, so rather than, because we tend to wait till the patient gets really sick. So if you think, it's going to happen, I think we should do it early. And this thing about rejection, retransplant rejection, steroids rejection, the problem is they would already have had ATG. So, and then, you can't give ATG again. So you'll have to ALG or something else. And the patient is, will be really immunosuppressed at the time that we're going for transplantation for rejection. So that's a really difficult thing for us to do.
That's exactly what I was going to say. Especially when we are doing a retransplant, we tend to give them low immunosuppression, like you said. But if you are looking at, like say in LDLT, how many times do we see PNF? Primary non-function mostly. Rare. If there is no surgical issue, then we are looking at AMRs also, correct, which has recently come up, and they're saying that probably that is the reason. So if you're doing PNFs, retransplant, or chronic rejections, where we are not sure, like Abhidip said, that it could be antibody-mediated rejections, which are not so well evaluated in terms of immunological aspects in our country mostly. So I would think that we should look at donor-specific antibodies in these patients when we are doing retransplant. That specifically will help us understand the reasons why there is a graft failure, and also to look at the post-op immunosuppression in these patients if need to be changed accordingly. Thank you.
So donor-specific antibody, yes, you're absolutely correct. But then again, it's not like it's absolutely proven, because patients with no donor-specific antibody do have rejection, and vice versa also. So But yes, you
But
must
that,
definitely
that
look.
would give us a roadmap to see
Correct,
where
correct,
we are
yeah,
going,
correct.
especially in these early cases of
Yes,
PNA.
yes.
Thank you.
And just to add for that comment about late rejection,
Hi.
we generally get with longer survival, mostly they are graft failures rather than, and some recidivism. And we have never used basiliximab or ATG as induction
Yeah, I think in your
therapy.
paper,
We
yeah, I
just
think
go ahead and do it.
Yeah.
And
Sir, I mean, like you said, in the retransplant, the need for grafts and venous conduit, all that would be required. And DDLT, you have the advantage that you have fresh vascular grafts available. Is there any clear-cut data showing that within 48 hours, freshly used vascular grafts are better than cryopreserved grafts?
Yeah, definitely. I think, yeah, definitely, because cryopreserved grafts, two issues. One is they also have arterial grafts, the risk of aneurysm formation is actually higher. And I think infection also is slightly higher compared to freshly used things. So that is recommended compared to cryopreserved grafts.
And sir, overall in the literature, what a little bit I'd gone through, it says that LDLT is the general preferred thing in retransplant. I mean,
No,
because the donor factors can be controlled, young donor, and complex surgery in the elective scenario. So what are your thoughts on that?
I mean, of course, the quality of graft will be better that way, but then technically it will be difficult. So the Japanese and the Koreans in their articles say, do not do LDLT after as a retransplantation. Okay. So particularly the first one was a DDLT, just do not think about it. DDLT, I think if it's a reasonable graft, definitely I think you can wait for that.
Just to add to that, if you look at the data, the outcomes after re-LDLT or re-DDLT, the survival is same. Exactly, but as sir has rightly pointed out, if someone has got a DDLT done before and you are doing a LDLT after that, Assan's paper in 2017 actually said the same thing. That is something should be contraindicated. But then as the experience gained, more and more centers started doing it. So it can be done, but first DDLT, second preferably should be DDLT. But if you talk about retransplant in toto, where primary is either LDLT or DDLT and secondary is LDLT or DDLT, the survival outcomes are same. Statistically, there is no difference.
Thank you.
Practically speaking, getting a DDLT in time for a second transplant in our country, it's I don't know,
Yeah,
it's not
possible.
And we are stuck with LDLT. So, most of the times, patients wait for. It's easier to convince them for a re-DDLT, for a second DDLT. They'll be ready to, but if you say one more donor in your family, then it's a problem.
Correct.
And we'll never get the ideal second LDLT donor, because the ideal donor would have been used for the first transplant. So there's always a problem there also.
Yeah, I mean, these are the very reasons why, retransplants just don't happen as common as it should.
Thank you. I mean,
thank
actually,
you.
You talked exactly what we hoped for.
Thank you so
much. A lot
much.
of practical tips and
Thank you.
Thank you.